I'd like to introduce three people who don't need introduction, but let me go through the motions anyways. Dr. Koki Agarwal, she's an internationally recognized expert in safe motherhood, reproductive health and family planning policies and programs, as well as promoting policy dialogues and advocacy for policy reforms. She has over 25 years of experience providing leadership to large-scale program expanding several countries. One of her key program that she has led is the USAID's flagship maternal and child survival program with a focus in 24 USAID priority countries, and a follow-on, the MCHIP, that most of you must be aware of, which is a $600 million flagship program. The second, absolutely honored to welcome Dr. Aparajita Gogoi. I'm sure most of you know her. She is, most of the time I've seen her speak at Women Deliver. She's an advocate and crusader for health and rights of women and adolescents. She's the executive director of an Indian NGO, Center for Catalyzing Change, and formerly it used to be known as CEDPA. And she plays a pivotal role in conceptualizing and implementing Center for Catalyzing Change. She is also the national coordinator of the White Ribbon Alliance in India, and she has over 24 years of experience. Dr. Dilys Walker, thank you so much, works jointly in obstetrics and gynecology and global health sciences departments at UCSF. Dr. Walker is also an affiliate faculty in the Department of Global Health at University of Washington in Seattle, where she was associate director for the Center of Global Women, Adolescent, and Child Health. She's also visiting professor in reproductive health at the National Institute of Public Health in Mexico, where she worked from 1998 to 2009. Her principal research interests are maternal mortality and morbidity, and she has developed a novel approach to emergency obstetric training, and most of you in this room might be aware of PRONTO, which uses highly realistic low-cost simulation and team training to improve both obstetric and neonatal outcomes. She's also the president and co-founder of PRONTO. Thank you very much. And I'm absolutely honored to moderate this session. Maybe I can. I'm fine. I'm fine standing when three powerful women are in the seat. Absolutely honored. So this is the first question. Thank you, Catherine, for this powerful talk that you gave and being involved in the study from the inception. Just to remind you that this study was conducted in one of the most challenging geographies in the world. Just the birth cohort, the population of UP is equivalent to Brazil. And so this team has done an excellent job, and more than just conducting and publishing the studies, more importantly, the effort that the team at Ariadne actually went through to deconstruct the data and explain so that we could, as the world, can understand and take lessons from it. So my first question to Dr. Agarwal, we just heard that the whole system is important. And that can feel really overwhelming, at least for somebody like me. And I'd like you to share any insights or strategies on how to successfully create system change. And you have been such a key driver of that. We'd love to hear from you.
Thank you so much. And I think it was really exciting to hear this, the study and the results, because it endorses and highlights the areas that we have been striving to work and improve across the countries where we work. I'll start with a little story because in my early days when I was an intern in India working at one of the largest maternity hospitals, I saw a woman coming in who was admitted for postpartum hemorrhage, and as per our protocol, we had to ask for her family to give a pint of blood so that we could replenish our stocks. And she was accompanied by her mother-in-law and her husband, and the mother-in-law was said, my son will not donate blood. He's going to get very weak with in the process, so we are not going to donate blood. And with the result, they decided to take the woman against medical advice. And I think it still bothers me to this day that how the system failed her, and which is one of the reasons why I think we need to look at the whole system when we are working to save lives of women and newborn and improve the system and the quality of care. So within MCSP, which works actually in 32 countries, we have really been trying to see how we can take the global evidence, the most recent global guidance from WHO, translate that at the policy level, at the country level, but then more than ever work with at the district level, because as we know, much of the decision making, the funding, the financing is shifting to that level. And we have found that unless we engage the entire district system in the decision-making process, in the improvement process, we don't find the change happening. So working with district managers, working with district people who are not necessarily that aware of what's happening at the individual facilities, but engaging them in the process. And I don't think I would be forgiven by this panel, including Aparajita, if I don't mention the role of the community and engaging them in the process and making them part of the social accountability fabric of how and when and how we can improve the quality of care. So I think at the facility level, we have been striving to develop systems, and many of the things that Catherine highlighted from the study are the areas that we've been trying to work on. What sort of approaches can work to build the competency of the provider that can that she feels empowered, she feels confident that she can save the life of the woman or the newborn. And we have found that using an approach which is more on the job, low dose, high frequency, which is providing them short bursts of training, but not taking them away from the facilities so that they don't lose time. And then supplementing it with strong mentorship. I think having repeated mentorship, we have used professional associations in many of our countries to be the mentors who can go join along with the Ministry of Health to support the facility-based providers. Many of the other system drivers, I think, we need to understand how they can work together by setting up quality improvement teams within the facilities, but drawing from the community and the district level to set up quality improvement teams. And I think when I see them working together to address the system issues, change happens. They are able to develop solutions at the local level that can make a difference. I just came back from Guatemala where they were looking at very remote facilities where there's very little interaction with the district level, but they had engaged the community to help them understand early signs so that women could be transported. I mean, just the data that you shared that these women only spend like 109 minutes at the facility means that they could be coming so late in the process that the facility is unable to do anything. So I think that looking at how we can improve the system as a whole, but focusing on the different elements of the system drivers that you highlighted. Another aspect of work that we have been really focusing on is looking at how we use data at the facility level. If you visualize it, if people feel like they're looking at what they're delivering and using it as a motivational factor to say, okay, we didn't do well this month, so how can we visually look at what's up on the wall and say, how do we improve it? But I think that the next challenge for us is that it's okay to put something laminated on the wall and have it data, the visualization, but for the teams then to take action. I think that's an area that we need to strengthen and work on.
Wow, thank you so much. Essentially, you're saying this needs to be a very integrated, system-driven approach where it's not just one component may be necessary, but they're not sufficient in themselves. And I think we need to have multiple of those and come from multiple perspectives and intervene at multiple points. And since you raised the community aspect of it, let me just skip Dilys and we'll get back to Dilys in a moment. And forgive me for that. But how do Aparajita, you coordinated a massive listening program from community, What Mothers Want. And you just heard about the systemness of it. How do we build this trust between the community and the health system? And what are those connections that we need to make?
Thank you also for referring to the What Women Want campaign. I think the one in India in 2017 and the global campaign, we were not surprised that the highest level ask was actually respectful care. Since then we have tried to engage with both women and communities on one side, and also the system, trying to figure out what kind of bridges we can build. And we have spoken to providers, intensive discussions, and we have spoken to women. Women, of course, we found that in India, all 7 categories of disrespect and abuse are prevalent. What we've also realized is that there is high levels of normalization and also acceptance. The disrespect as kind of defined by women were also aspects like a C-section being done or a referral being done without really explaining to her or her family. So it's not just what's happening at that moment in time, but also not being part of the decision making. Women also talked about how not being really given a choice, whether it was birthing positions, consent not being taken, let's say, before a PV. So that there's various doable, smallish kind of aspects that the system can invest in to gain the trust of women. Now, on the side of the providers also talk about how women come in at the last moment. We talked about 109 minutes. They talk about this no birth preparedness to fall back to. They also sometimes say that these are illiterate women. I don't think even if I explain they will understand. They sometimes believe in it very strongly when they say, after all, I'm saving her life. I don't need to be polite to introduce myself, and I'm doing my job. So I think there are both are working on somehow kind of parallel lines, but we are working with some facilities, about 21 facilities, to figure out how do you actually build the trust. And what we have recommended is, first of all, that there has to be a policy push. So whether it's zero tolerance for disrespect and abuse, that has to be mandated in policy protocols, programs. We did a review of pre-cervix textbooks, and there was no mention. Even the MBBS curriculum in India, the doctor's curriculum, didn't really have anything on respectful care. Forget about respectful care, on empathy, patients' rights. So we are trying to advocate very hard with the professional associations that at least include chapters or mainstream some of these elements in your textbooks. So pre-service, in-service protocols, guidelines, I think we need to make an explicit mention of how do you gain the trust. The other thing I think is really kind of invest on some of the aspects that can be provided without too much of investment, like birth companions. So the government of India made birth companions mandatory, and I'm sure that that's going to go a long way in ensuring that women feel more secure, more respected. The other thing is also, I think we need to really work on some sort of a grievance redressal mechanism, because when we speak to women, they also say that even if it happens, I don't know where to go, I don't know what to say. Doctors also say, oh, we didn't know these things were happening. So I think some sort of a mechanism where the two are connected. And like Koki said, I think we really have to train and retrain our workers. Yes, clinical skills are extremely important, but we also need to talk about empathy, patient rights, behavior, communication, and in kind of the environment where we work in, really working with providers on gender sensitivity, on social inclusion, because we have also noticed that a lot of these things happen when it's kind of a triple whammy. If you're poor, if you're a woman, if you belong to a lower caste, and you're illiterate. So those are some of my...
Yeah, thank you so much. And that's where I spend most of my time, and it's been 15 years since I've been embedded in the community there. But before, when as a clinician, I really never knew about person-centered care till I met Dominique. So all I bring this to illustrate the point that we are so obsessed with just kind of trying to provide a technical intervention that we almost forget that there is a human there. And which essentially brings me to this whole question of, if you just look at from a women's perspective, and you have every reason to feel extremely upset, and it's about the whole quality of care that is being provided, the whole range of disrespectful care that is available. That brings me, but if I just go back, even working in a large hospital in India, for instance, and that takes me to the health providers, and particularly those at the front line of childbirth. And that's a question to you, Dr. Dilys, because that must have been the inspiration why you actually founded Pronto. And so I want to please tell us, how big is that problem? How widespread is that challenge? Because we need to empathize with the providers as well. I don't think they're simply doing because they want to do. So we really would appreciate and would like to learn from you and shed your, from your global experience.
Thank you very much. I think that's on. No. Hello? You could probably hear me anyway. So thank you very much. And first of all, I just would really like to congratulate the Ariadne team, because 2 million data points, and that is a new definition of unpacking if I have ever heard of it. So I think we all are very appreciative. And I also was thinking, as the founder, and we also have Susanna Cohen, who co-founded Pronto with me. We've now been doing this for 10 years almost, which is hard to believe. And 10 years ago, people thought we were crazy, because people thought you can't do it all in one time. So instead of this issue of teaching people how to manage hemorrhage or preeclampsia or birth asphyxia, it's how do you deal with an issue and just let a team figure it out. And I think we have to stop talking about providers and talk about provider teams, because no provider should ever have to be thinking about this as an isolated person managing situations that can only be managed together. And that includes one provider, because that provider is going to be passing off care, is going to be having a helper. And I think we really need to think about, I want to start a new movement instead of patient-centered maternity care, P-squared centered maternity care, and it should be P-squared. And that gets at this whole idea of we should be, I'm thinking about the language of the dyad and the dyad, which is at the core of our work, but it really is the triad. And that if we don't really start considering that provider and what that provider needs, they will never be able to turn around and provide the care that all the women around us need. I was also thinking about this whole idea of, we're talking about job performance. Quality of care is job performance. And job performance is highly linked to job satisfaction. And I know I get my job satisfaction survey every year, and I respond to that. And the thing is that these providers are part of a community. They are also part of the geographic, the institutional, the family community that they live in. So if we don't think about them as community members with real stories, with real hardships, and it took me about 5 seconds to think about, of all the Pronto trainings that I've been involved in and done, there's been one we've had to delay because we had to pause for the funeral ceremony for the physician who'd been murdered outside the facility the week before. Another training we had to pause because the trainer arrived late, or one of the participants arrived late because he had been robbed and beaten on the way to the training. The providers who talk about I think it's great that we're bringing birth companions into the room, but when you have providers who are afraid to resuscitate a female baby for fear of retribution by the family, we have to figure out how do we provide support in those kinds of situations. And I think that one of the keys to our success in Pronto is this issue, the sort of concept that I haven't heard mentioned is mutual support. So at the core, I think what happens at the end of our Pronto simulation trainings and teams is that those individual providers end up feeling supported. We end up understanding that there is someone that they can call to. In order to do that, you have to create a safe learning environment. Now, recently, we've been trying to really explore this issue of safe learning environment in the Pronto trainings. Like, how do we make sure that when this gets replicated at third degree, that issue is maintained. Turns out in Hindi, there's no translation for safe learning environment. And we had to have long talks like, how are we going to describe a safe learning environment where you can make mistakes, where you can talk about the mistakes, you can explore them. So I think that issue, the safe learning environment, safety between cadres, the doctor-nurse issue, we've heard a lot about that. If we can't build mutual support and understand what that is and how that is critical to outcomes, I don't think we're going to get there. And I also am a little bit concerned about the, safety, quality of care, that lots of people are now turning to us as well to use the kind of work we do in simulation to do assessments, to get or understand what is the readiness, what is the quality, where are the gaps. If we do that, that becomes an assessment rather than we become a learning tool, and we've had to push back a lot against what is the value in doing those assessments, certainly not on an individual level, but perhaps on more of a team and a system level, and that I think I'll leave it there. Thank you.
Awesome. Thank you so much. And I'll just bring this session to an end with just one last question. And so we heard the challenges, we heard the opportunities and the possibilities. If we actually put our acts together, harness all the evidence that we have, continue to discover more and think on our feet, do you think primary healthcare centers, as it is, you're optimistic that it can actually deliver high quality delivery and childcare?
Are you turning to me first?
Yes, or you can in any order.
Well, I think there's a short-term answer and a long-term answer.
Yes.
The short-term answer is, I think in many settings and many geographies, the primary health center is the best place to get their care there is, and I think we need to continue to support that until we have a better solution. I also think that it's true, all women deserve the capacity to have a C-section within 30 minutes if that's what they need. I'm concerned that that's not always what they need when that's what they're getting.
Right.
I was looking up last night, there was a recent, not too recent, the publication about WHO's recommendations for antenatal care, a positive pregnancy experience, going beyond survival. I was searching for a similar thing for birthing experience. And I think that, we are so focused still on the surviving the lives that we're forgetting a little bit beyond the survival issue. So I'll leave that because I know we're short of time.
Yes, Dr.
Maybe I can just build on that. I think that definitely I feel like if we have primary healthcare centers with the ability to provide the services, we can do it. We have to have the effective referral alongside. And I think that is sometimes where the system breaks down because either women come late or there's no system of figuring out how and where they're going to get referral. And some of the work that we have done in Guatemala and Mozambique actually highlight this issue where we've tried to set up, use technology to some extent by looking at WhatsApp and how they can immediately reach out to many physicians who can respond as to what needs to get done. And then that system of not only referring the woman, but somehow following her back where she needs to go back and be taken care of.
True.
And just building on what Dilys was saying about that continuum of care so that it's more of a positive experience for the woman and her family.
I think it can work provided primary health centers are doing what they're supposed to do. So which would mean that you have your staff positions filled, you have your supplies, you have a good referral system, because I think referral in countries like ours work both ways. Are the frontline health workers skilled enough to refer on time, and then what happens when the referral happens from a lower level facility to a higher level facility? I think referral is a crucial link here. Also, I think Government of India, for example, is introducing the midwifery model of care. I think those will go a long way in ensuring that women get good care at the lower levels and everybody doesn't have to be rushed to the tertiary level care. And I also want to talk about how if you involve community and women, I think primary health centers can function better. Simple things like I went to a hospital which had the birthing positions kind of painted on the wall in the antenatal clinic. It was a message that when we asked women, what do you understand by looking at that? They said, which means that when I come for my childbirth, this hospital is going to allow me to. So some of these subtle but important things. So yes, not as it is now, but if you strengthen, it can happen.
Thank you very much. It has been a fascinating panel. Thank you, three amazing women. And I'll bring this to an end. And I just heard in one of the talks during this Women Deliver, how do we move from a safe birth to a secure birth? And how do we add experience to that entire? So I think this is fascinating time for quality of care and the quality of experience at the time of birth. And all of you here, including those in the room and not in the room, I think you're playing an incredibly important, both intellectual as well as catalytic role in moving the policy and program forward. For somebody like me who is embedded in UP out there, I am very grateful and thank you very much, because what you do really helps us make those changes that are needed for our mothers and babies right there on the ground. Thank you so much.
So thank you so much, Vishwajeet, Dilys, Koki, and Aparajita, for this wonderful panel and discussion about how we can make a difference. And it's great to hear the passion from you all, but how do we improve care? And it's so encouraging to see the progress that's being made. I just want to acknowledge all of our partners that made this work happen. As Evan mentioned earlier, more than 350 study team members, 600 healthcare providers, the government of India and government of Uttar Pradesh officials, but most importantly, the 157,000 women who allowed us to follow them, interview them, and learn about their lives and their lived experience. We are eternally grateful for this process and pathway to be able to understand more about making BetterBirth a reality. So in addition to the published report and the USB that you have there in front of you, we have also launched a web portal that has all the publications, links to the information, as well as our contact information. And we hope that you'll share this with your communities and colleagues to move this information beyond Vancouver, beyond Women Deliver, to every corner of the globe. What is consistent regardless of setting is that we need systems thinking to make sure we're achieving outcomes for women and newborns. And there is a role for all of us, implementers, donors, policymakers, researchers, community members, family members, in achieving this change. We have to be partners to make this journey happen, to reach the goals of better birth for every woman, every newborn, everywhere. So just to end, we know that change is possible. Let's go forth and make the difference worldwide. Thank you all so much for joining us.